everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. Your point of, capnography fits all of those. Capnography is mandated, right? In the state of Ohio, we have specific waveform capnography.
Waveform capnography is mandated.
Not a color changer, not a colorimetric, not a capnometer, which just measures the number.
Yep.
You have to have two parts to have capnography. You have to have the waveform plus the number, right?
Yep.
There was a situation in our own house here recently where they were only getting the number on an advanced airway patient. And that particular monitor needed to be reprogrammed, but the waveform didn't automatically come up. And this was a life pack. And they needed to scroll around into the waveform section.
And choose it.
Enter, select the capnography waveform. Subsequently, we've gone back and fixed that, but there was a protocol or a scope of practice variance there because they didn't take the time. They're like, "Where's the waveform?" They knew they didn't have it; they just didn't know how to go get it.
Waveform is so. If you know how to read it, it's just as important as an EKG. Maybe more so because we're talking about breathing now, and that's.
Yeah.
But you can see tube leaks, you can see overinflated cuffs, you can see underinflated cuffs. So not to make this a whole capnography lecture again, but reading capnograph is definitely something that you can do.
Even as an EMT.
Yeah.
Even as an EMT.
Yeah, absolutely.
Yeah, it is an EMT skill. I'm glad you brought that up. And then as for programming your monitor, a lot of people like to turn on their monitor and they look at 2-3 AVF, and then you're starting to see the trend shift to like 2-3 or whatever lead you want, 2 and whatever lead you want in the second spot there, and then end tidal is the third slot, just because we're utilizing it in so many different ways, whether it's nasal cannula or if you're placing any type of advanced airway or you're bagging them. And that's also a good reminder too to the EMT or the paramedic, hey, I'm looking at it on the screen and I have the dots going across it, I'm not utilizing it. Maybe that gives people a reminder as like a trigger, I need to utilize it more. Not to make it all about capnography, but I think it's very important to include it as one of the things that we do. But it's also good to know how to troubleshoot your equipment too. So if you turn it on and it doesn't appear, what do I do? How do I get to it? No different than pulse ox was one of the things we actually didn't talk about in the last item. Is I actually like utilizing the pulse ox more for the SBCO portion of it for firefighter rehab. If we have carbon monoxide, those things we kind of did not cover, leaving that piece of equipment on their finger for that as well.
Yeah, absolutely. In this particular case I was talking about is their A-job, their monitor, you plugged it in, the waveform automatically came up. They came and they were on the truck and they plugged it in and they got the value, but they didn't get the waveform, and not understanding it. Was just the way the machine was programmed, right?
Yeah.
So again, goes back to knowing your equipment, and even the something as simple as that, right? Somebody checked a value or didn't check a value when they set your device up, right?
And know that if you have somebody vomit, you're probably going to need to replace this.
Yeah,
it will get clogged up really quick, and you'll start getting false values. So,
if they vomit and then have subsequently aspirated, and then it's coming up the tube, because if they're vomiting and it's coming up the tube, you have a very, very serious problem.
Yeah.
Your advanced device is not where you think it is, right?
Good point.
It is not where you think it is. But certainly
blood, vomit.
We've had the blood. We've had the blood issue for sure, and then it's been like the topic you discussed earlier, and then we've had to change them out. And the key to your point, Caleb, is a lot of people need to plug that into the monitor first.
Let it calibrate.
And then put it on the patient. That's where a lot of people go wrong.
So I just wanted to talk quickly about these Thomas tube holders. In this area, they're fairly ubiquitous tube holders. Obviously, there's everybody and their mother who wants to try to make a buck in EMS tries to design a better ET tube holder. But I think
work well.
I think these probably have the most staying power in our industry, or at least in this area. There's 3 different kinds. I've got 2 of the 3 with me here, and I want to point out kind of their downfalls. There's 2 dark blue ones, and then there's a light blue. There's a very light blue one as well. So the very light blue ones, this opening here, is only satisfactory to hold an endotracheal tube. You would not be able to get it around the diameter of this King airway. So this, I'm just going to call it their second generation stuff. their second generation stuff has this larger opening, which would accommodate a larger supraglottic airway, like a combi tube, or in this case, a King airway, a Cobra, a PLA, whatever other crazy big ass tube airway you might have. When we enter into some of the oblong airways like iGels, with this really, really wide bite block, Thomas makes a device specific to that with this ever increasingly large opening here, right? That will also accommodate an iGel, but you can use that, of course, all the way down to an endotracheal tube or something smaller. I've been on calls where nobody really recognized. And this certainly was early on when the supraglottics first became more popular. It was what burned you the most was the light blue ones into these blue ones. Now that we're transitioning, or departments that have already transitioned to iGel have already suffered through this. It's trying to jam this into here. Can it be done? Sure, with a mallet and some work. But there is a proper tube. So make sure that whatever you're using to secure the tube, whatever commercial device, and I don't know about your guys' feelings, it's my strong belief that whatever you use, doesn't have to be this, should have some sort of bite block in it. Things like the iGel we'll talk about later have a bite block built into it, but many of these other supraglottics do not. But I'm just a strong personal opinion, is a strong believer in anything with a bite block baked
And we
into
know
it.
that because if the patient becomes clenched down or trismus, they might actually bite to the tube and occlude their own airway again.
Yeah, they seize whatever. Right. We don't want half the tube in your hand and the other half in their trachea.
And a lot of that, I think, took care of itself after like the first gen came out, because then you started to see these come out as like a package. You know what I mean? There was a kit. There was the lubricant for lubricating the distal portion of the King airway. It came with a tube holder with a bite block. All those things were kind of baked into it to make it easier, because those things occurred.
Those exact things occurred, right?
People were not equipped,
Somebody somewhere, hasn't checked the jump kit and the last out engine, and
Last out engine.
we've got all supraglottics. Let me again widen my all supraglottics. You probably shouldn't put in if they've had any type of caustic substance ingestion, or
That's a good point.
because we don't want to permanently affix this to their oral pharynx and melt it in. The other thing is, we were talking off camera, is any drugs down the tube. Now, that's for the most part, specifically in this area,
Kind of by the wayside.
It's by the wayside, right? There really shouldn't be a situation where we would have an opportunity to put a drug down the tube, but
And that's because of the use of our IOs that we have.
yeah, exactly. You should be able to come up with vascular access in some way, shape, or form. The risks of, and the reason you can't put meds down, a couple of reasons why you can't put meds down. First of all, most of it's not going to make it into the lungs to begin with, right? It's all going to pool, or it's going to be above the glottic opening to begin with. And secondarily, there's some risk. We were talking about how real that risk could be. It's enough to make the statement of, you might splash that down on the vocal cords, and they might laryngospasm and cause a, hopefully temporary, but some sort of an airway obstruction simply by the choice of putting the drug down. Again, probably overstated, but why take the risk, right? Do the thing, do the IO if you can't get an IV, if you can't do other things, if the patient's seizing, we know, Versed IM is as effective at a proper dose, is as effective as IV, right? So, and IO. So, case dependent, but really no meds down the tube is a good general practice for all supraglottics.